Thank you very much. It is a real delight for us to be here. I'm Amy Williams. This is Krisa Ryan. We have a wonderful story to tell you all, a story about a very successful and innovative clinical practice redesign, dealing with some of the most complicated patients that we have in our system. This was the Reengineering Dialysis, or the RED project, redesign project. I'm actually going to start in the middle of the story. I'm going to start with a patient quote. Patient told this to Krisa Ryan during her design research. Patients don't get vacations. Patients don't get vacations. Think about that. If you're a provider, this probably makes you very sad. It made me very sad and all of my colleagues. They're absolutely right. Our patients with very, very complicated chronic diseases never get a vacation, not 1 minute of a vacation from their disease. I get a lot of vacations from my patients' diseases. I go home at night, I don't take their chronic disease with me. I go on vacation with my family, I don't take their chronic disease with me. But they never get a vacation. It is the context behind this quote that we're going to share with you today that really became the compass for our innovation and for our practice redesign. It was absolutely a ton of fun, a ton of fun. Our goal was to look at our patient experience, to enhance it, to implement best evidence-based practices, and deliver them in a team approach at the bedside. That was our goal. That's why we did this. Well, we also did it for another reason, and that had to do with Medicare. In 2001, they started to bundle the payment for dialysis care. So we got one lump sum of money to care for our dialysis patient for the year, to cover their dialysis care. They also were going to hold us to quality metrics that they had decided, they meaning Medicare, really reflected the outcomes for our patients. So we knew we had to be better and we had to cost less. Why was this so important for Medicare? Because there are a heck of a lot of people in the US with chronic kidney disease. Over 26 million individuals have something wrong with their kidney. Many of them, kidneys, many of them have a progressive disease. This accounts for almost 30% of Medicare annual expenditures. Wow, very important to Medicare. Over 570,000 individuals in the US are on dialysis, accounting for about 7% of Medicare costs and greater than 10% of Medicare expenditures. So we needed to move fast. It cost a lot of money to keep somebody on dialysis, and it sure cost a lot of money to care for someone with complicated chronic kidney disease. So we got together all of our experts, all the dialysis docs in the whole Mayo system that were experts in dialysis, all the NPPAs in our system, all the dietitians for dialysis, all the social workers for dialysis, all the finance experts for dialysis. And we started on our re-engineering dialysis journey. A couple months after we started, we started to collaborate with the Center for Innovation. And they said, hey, we can help you. We can give you the voice of your patient. And we said, oh, thanks. We know our patients. They're with us 3 to 6 days a week. They come into the dialysis unit, and they're there from 3 to 5 hours every single time they come in. We talk to them all the time. We know exactly what they want and exactly what they need. And the Center for Innovation said, great, but we can help you. And they introduced us to Krisa Ryan. And Krisa Ryan is a designer. And we thought, well, this is pretty nice. Krisa is sort of funky. She is incredibly smart and articulate. She'll be fun to be on our team. Plus, she's a lot younger than most of us are on the team. And so Krisa then, we invited her on the team. As a designer, we had no idea what she was going to do. We didn't know what a designer did. They designed products. How was that going to fit into healthcare redesign? So she came over from the colored side, with lots of color to the dark suit, the black on black suits, to help us figure out what our patients need, what they needed. And really, we thought just to confirm what we already knew to legitimize our plan. I'm going to let Krisa talk about her joining the team.
I started on Project Red a little over a year ago, joining the Black Suits team, as Dr. Williams states it. Designers like black, though, so that's good. So when I started this project, I started having conversations and doing observations with lots of different patients. And I heard this quote pretty serendipitously right at the beginning. And this was a big statement to me in so few words. And it begged a lot of bigger questions. And I know for myself, I was thinking, why the word vacation? What is it that patients want vacations from? Is it a vacation from their disease itself? Is it from the treatment processes? Is it from just the maintenance of care?
Or the providers, which was what we were thinking.
So what were these burdens, and how could we as a team try to alleviate these burdens for them? Or better yet, if patients did in fact get vacations, what could those vacations look like? So I remember the very generous man who made this statement to me, and after he said this quote, he went on to define and describe other circumstances in his life that had become very consumed with preventing and learning and translating and educating and communicating with the care team and with his family, with his community, with his job, but also just for himself, trying to understand this new norm. But a lot of what he went on to describe wasn't just medical. There was an awful lot of non-medical in what he was saying to me. And I wanted to understand this, how interwoven this is, the intersect between the medical and the non-medical for this patient population. Because from purely just a medical standpoint, this patient population is on average 15 medications. They are receiving dialysis treatment anywhere from 3 to 5 hours every other day, and that doesn't include the on and off time or the transportation it takes to get there and back home. They're also sometimes procedural patients, so they could have catheters placed, they could have fistulas placed just in order to receive that 3 to 5 hours of treatment every other day. But on top of that, they were very complex patients. That meant that they could have other diseases that are primary or secondary to kidney failure. They could have diabetes, they could have heart conditions, they could have other system organ failures. They could have a lot going on and be very sick for many years. And also, even shockingly to me, I was such an outsider when I started this project. To be very honest, I didn't even know anyone with kidney failure when I started this process. So to learn how severely chronic these patients were was shocking, because not all of them have the option to have transplants. And for those who don't have that option, this is truly a life-preserving treatment for them. This isn't a vacation. It isn't a 9 to 5. They don't have a free day. And so this quote, when he mentioned this to me, it really led me down this journey over the next couple of months of doing design research to understand just how interwoven the medical and the non-medical is. And I was so graciously welcomed into all of these different spaces and environments by these wonderful care teams, and also by patients in inpatient settings, outpatient settings, even eating coffee cake in their homes with them and their families, trying to understand their day-to-day life and how this was becoming a new reality for them and how they were trying to manage this, all while doing it on their own terms as well.
So while Krisa was embedded in the lives of our dialysis patients and really learning about dialysis and what it's like to have a devastating chronic illness that changes your lifestyle dramatically, the rest of the team, the experts, went to work and we did our process mapping. And we looked at from when the patients were diagnosed with kidney disease to when they need dialysis and then to when they die. And we saw that we had many, many gaps in our process. One of the biggest ones was at the beginning, and that 65% of our patients started dialysis in the hospital in the middle of a lot of stress and acute illness. We were asking them to make big decisions, decide, do you want dialysis tonight? You don't need to do it, but of course, if you don't choose dialysis, you'll probably die by tomorrow morning or in a couple of days. What kind of dialysis do you want? Okay, now you're on dialysis, goodbye, you can be dismissed from the hospital. Good luck with your new life. We realized this did not set our patients up for success in the future. We need more of the story. We know from studies that for individuals over the age of 70 on dialysis, 2/3 of them regret starting dialysis. And 50% of those individuals started dialysis because their doctors wanted them to, not because they wanted to. And we also know that the symptom burden of disease does not change at all once someone goes on dialysis. So we realized we had some huge, huge gaps. And we needed to turn to Krisa and her research in order to find out where to go from here.
So our practice redesign was really at a point where the team was capturing very real and important quantitative data around many, many different touch points in the dialysis services system. And at the same time, patients were also sharing somewhat of an invisible factor. They were actually sharing a lot more around the movement in the system, around these, the transitions from touch point to touch point. And when we started to overlap a lot of this data, as a designer and kind of being an expert between these two different languages of the care team members and the patients, this information started to really make me take a step back to understand that, in fact, care teams and patients aren't polarized. They're not on different sides. Much of what they were saying was, in fact, geared towards the exact same goals. Their intentions were positive intentions that were very much in alignment with one another. And I was seeing firsthand through different observations and interviews this completely superhuman care team go so far above and beyond their job description to stay after hours, to have longer critical conversations with patients, to help them understand what this disease and what this treatment may actually mean for their life. And so this seemed like a great opportunity to come together as a team through the perspective of the medical and the non-medical. So we used a tool like personas here, and we as a team made 8 personas, and I'll share 4 of those 8 personas here. But what we were trying to understand were similarities and differences in patients in the medical and the non-medical. So you can see their medical trajectories and how different those look. They start in different places. As Dr. Williams stated earlier, 65% of them start in an outpatient setting. A lot of these patients have different options of how they can receive dialysis treatments, and they have options in where they can receive the treatment. So their trajectories had many different pathways. They had many different loopholes in this, but we were able to not only capture those touch points, but capture the narrative and the context of their actual life and what it meant to them in their life to be going through this disease. So at this point, these personas weren't an end-all, be-all tool. They were just stories to help define real, true-to-life experiences and share those common goals and share those common intentions. And so these personas helped us have some of those conversations and look at this from the lens of trying to create a different type of system that allows for all of the change that we see in all of these personas. There's always going to be change. Patients are always going to have different options and go on different pathways, and we might not be able to 100% of the time get them exactly on the path that they need to go on. That's our goal, but we can try to create a different future for them. We might not be on that, we might not see that future with them 100% of the time, but it's our job as educators and care team members and innovators to try to create these flexible and sustainable systems to meet these real conversations and meet the patients where they are.
When Krisa presented these personas to the care team or the redesign team, the room was absolutely silent. It was a very personal experience for every caretaker in that room, whether you were a physician, the dietitian, the social worker, the MPPA. In these personas, we saw every single advanced chronic kidney patient that we had ever treated represented. And we knew that we could have done a better job with those that were no longer with us if we would have had this extra information. The personas and these 5 influencers or needs became the compass and the measuring stick that we judged all interventions against. We went back to the state that Krisa designed, and we realized we couldn't separate the medical from the non-medical. And when we looked at the trajectory for our patients, we found points where we could implement interventions that we tested first with personas to make sure that they supported the patients and enhanced the influencers. We were able to increase communication and provide consistent communication across the trajectory of their disease. We were able to better define our team so that everybody's role on the team was known by the other members. We also embedded palliative care physicians on our team so that these critical, honest conversations started early in the patient's progress of their disease. And in fact, the palliative care doctors have trained all of the nephrologists and all of our RNs and MPPAs to be super users of palliative care so we can initiate those conversations right there in the dialysis unit or with these patients that we see so often. We also developed interpretable educational materials. I say we, but Krisa did. Materials that they can look at and they can translate within their own preferences and healthcare goals so they can make the right decisions. And we start the education early on and we morph it as their disease changes and they change. By doing this, we were also able to standardize evidence-based best medical practices in our dialysis units and chronic kidney disease units or clinics. Our patients were part of that. So we did improve delivery, we improved our patients' experience, and we were able to standardize with evidence-based best practices. What was our outcome? Our outcomes are spectacular. We have decreased our hospitalizations by 40%. We have significantly decreased the number of in-hospital dialysis runs, meaning we're keeping our patients out of the hospital, or the patients are making the decisions with us whether or not to choose to go on dialysis. Patient satisfaction has improved. Provider and team satisfaction has improved. We know how to depend on each other now because we know what each of our roles are. We have also been able to meet our quality standards better than we ever have been able to. And we're hoping to influence CMS to have better measures of quality that really reflect meaningful patient outcomes. And we have huge cost savings by decreasing unnecessary health spending for these individuals that probably also would put them at more harm with other tests, et cetera. So the bottom line here and the message is, with new tools through design thinking, we can really, really innovate in clinical practice redesign. We need the whole story, and that's what Krisa's talents helped us to find. So yeah, patients with very complex chronic diseases don't get vacations from their disease. But with these right tools that help us build flexible, appropriate medical care avenues for our patients and systems, we can decrease the burden of disease and the fatigue of the disease and enable shared goals. Thank you very much.
That's a great story, and those numbers are really spectacular. But let's think even a little more tangibly about this, because in the chronic care space, there are a lot of commercial drivers because of the numbers that you originally showed us, 570,000 people with chronic kidney disease. I mean, those are huge dollars and are huge opportunities for institutions to create, commercial ventures that aggregate people with needs and supply sort of commercially and perhaps superficially attractive add-ons that maybe don't contribute to the therapeutic experience, but are certainly an alternative to traditional hospitals. I mean, are we headed to a nephrology spa model somewhere where you go in and they do look at the designer, look at that, where you get your nails done while you get the dialysis treatment, a sort of sports bar kind of concept for nephrology, or even a casino where you could go and during the time that you're in dialysis, you're also playing a bunch of games and have a chance to win maybe some extra dialysis, who knows, or maybe Percodan, I don't know. Go ahead.
I'd love for them to win extra dialysis, but these patients are often so complicated that people are afraid to really do those sorts of things. They do have dialysis cruises where you can pay to go on a cruise and you can be dialyzed on that cruise. We allow patients to exercise with exercise bikes while they're doing dialysis, or they're not bikes, but they're pedal machines. Anything we can do to make the dialysis treatment more enjoyable is wonderful. It's a great time to educate patients and build relationships when they're dialyzing. There are for-profit chains for dialysis. They are held under the same standards we are. We hope that CMS will not allow cherry picking, that the sicker patients go to the nonprofit chains because they cost too much to take care of. We'll see how they manage that. But I would love for there to be innovative ways to improve the dialysis experience for patients.
What are the limitations, Chrissa, when you sort of throw the, Jello at the wall and see what sticks? Does the limitation come from, well, that's too wild, or I guess too funky, to use your words? Or are there real institutional limitations in the sense that reimbursement will reimburse for this, but not for this? If you put too many nice curtains in the room, you're getting beyond the business model. What are the limiting factors to really improving and enhancing and thinking big about making this experience as positive as it can possibly be, even beyond what you've already done, Chrissa?
Well, I think we wanted to start from the beginning to understand what was it that patients were looking for in their care. And so through Medicare, we get paid more if our metrics are higher. But the point that we were trying to look at was, why would patients want their metrics to be better? How can their life be sustained with this disease? And so it's kind of a translation of their life and their life goals into ways that we can try to meet those metrics. So I think for the team, it was such a great experience as a designer to throw out a ton of wild and crazy ideas, and they were very welcoming because they do have these same goals as the patients, and they do want to help these patients, and that was so obvious in everything that I had seen. So I think I was lucky with the team that I worked with.
Doctor, on the nephrology cruises, dialysis cruises, to use a model there, do you find in your practices that the dialysis population likes to aggregate collectively, or is it pretty much everybody's in their booth and they have their own sort of personal sense of alarm, tragedy, fear, worry about their own health, and that it's very, very difficult to get people collectively to experience dialysis in the sense that maybe you could turn the metrics into a game where, Cindy over here is winning, Mrs. Gillespie's not doing so well, maybe she needs to do something with her diet, but maybe next week she can beat, George over here, who was, the winner, the champion this weekend.
Very good question, and I think it depends on where the patient or the person is in their trajectory of their disease. When individuals start dialysis, usually they want to learn as much as they can. They're a bit overwhelmed and they keep to themselves. But the dialysis unit community is a tight community. When somebody dies, everybody feels it. One of the things that we are implementing is group education for both family members and the dialysis patients, because they do learn a lot from each other. And having it more facilitated than just having people talk and share during their dialysis is probably a better way to do that. So we have implemented that. But
when you say facilitated, you mean mini cruise leaders within
mini
the
cruise
team.
leaders,
Yeah.
maybe having a provider there, the social worker, the dietitian, a physician, somebody else on the care team with them, so that the conversation flows, but we can make sure that some of the misperceptions are clarified.
So the takeaway here is the design of the environment for the delivery of dialysis care can improve a patient's or invigorate a patient's embrace of the reality of their condition, and maybe shorten the time that it takes for them to go from fear and uncertainty to clarity about what it is that they're going to be able to do to help their health outcome.
Actually, if you look at the influencers, the big influencers are relationships, communication, education, very little to do with the environment, but we all feel better when we're at a place that's more convenient, et cetera. Krisa really taught us that it's not how comfortable the chairs are or the curtains. It is really the relationship with the people in the dialysis unit. In fact, one of the things that shocked us, one of our goals is to get patients home to dialyze in the home setting. We know those individuals do better. They stay out of the hospital, they have better nutrition, blah, blah, blah. But we learned from Krisa that the care team was the major support for our patients. So we're pushing them out the door, and no wonder they don't want to leave. One of our tactics is going to be, how can we still be their major support and keep them at home? It's really the relationship and the communication that allows someone to be more successful on dialysis.
Great team, great collaboration. Thanks so much for sharing this story.